Hi there, I'm Dr. David Weisman. I'm Director of the Clinical Trial Center at Abington Neurological Associates in Abington, Pennsylvania. Today, I'm going to show key educational points for patients and caregivers who are interested in taking these new anti-amyloid drugs. So the first question is, what are these anti-amyloid medications? So they're the medications that can slow down the cognitive decline in people with mild cognitive impairment due to Alzheimer's disease or early Alzheimer's disease. That's the appropriate use. And the way that they work is that they stick on and induce white blood cells in the brain, those are called microglia, to eat what the monoclonal antibody is attached to. As it eats away the amyloid out of the brain, it reduces amyloid burden, and that seems to be highly correlated with slower progression. So this is a new era in Alzheimer's disease because historically, we've only been able to treat symptoms. We've been able to give medications for memory loss and for neuropsychiatric problems of the disease, but this actually targets the underlying physiology, the underlying pathology. It reduces the sticky stuff called amyloid, which is an abnormal protein in the brain. By reducing it, again, better outcomes in the future. In general, the data shows it does not stop or reverse Alzheimer's disease, but it slows down the disease and helps patients stay in an early stage for longer. And so that increases the time before people need, they're making mistakes and they need assistance to do tasks, etc. What treatments are available? Well, there are two that are on the market now that have been gone through drug discovery and development and are now approved. The first one is called lecanemab. It's an IV given every 2 weeks for 18 months, and then after that, it's slowed down to every 4 weeks, and it takes about an hour-ish to infuse and then observe. And the second one is called donanemab, and that is given, again, IV, but every 4 weeks, not every 2 weeks, every 4 weeks, and it only takes 30 minutes to infuse. It's a bit of a lighter touch, and after 18 months, we stop it. It hasn't been studied after 18 months to satisfaction, so we stop the medication eventually. The other one, lecanemab, the every 2 week one, we continue, we just slow it down. So who's a good fit? Who can take these anti-amyloid treatments? First of all, people with mild cognitive impairment due to Alzheimer's disease or very early Alzheimer's disease, meaning that functionally they're doing pretty well. Need minor assists for certain things, maybe appointments and finances, but they're not really dependent on other people. They test out pretty well. So memory loss, yes, but not a lot of other cognitive problems with language, visual spatial ability, or emotional controls, stuff like that. We must have amyloid positivity, meaning that we have to have evidence of that amyloid in the brain. Without that, I can't get the drug. There are some people who look like they have mild cognitive impairment, but they don't have these sticky proteins. And if they don't have them, there's no target for the drug to bind to. No target equals hold your fire. When we see the amyloid, that's appropriate to get rid of it. The patients have to be willing to undergo the burden of treatment. So they have to get the infusion every 2 or every 4 weeks, and they have to get many MRIs for safety. And more on that later, but basically we're looking for brain swelling in the brain. And it's not approved for people who are fine. The amyloid builds up 10 to 20 years before the onset of any symptoms, and that's not appropriate to treat. And on the other side, it's not appropriate to treat people who are more moderate or severe. People have to be just right, like Goldilocks zone, MCI, mild cognitive impairment, or early Alzheimer's disease. That's sort of where we're looking to bend the course of the disease. And then if people progress on treatment, you can de-escalate the drug and cease therapy when the disease progresses into the later part of the disease. How much do they cost? the amyloid PET scans to verify the presence of these proteins, that's now covered by Medicare as of about a year ago. And the anti-amyloid therapies are also covered by Medicare as of about a year and a half ago. There may be some additional coverage and fees and supplemental and Medicare Advantage, and then the other insurances can be difficult, but right now it's covered by Medicare. How effective are they? How well do they work? So they both show slowing of disease progression on the endpoints that we use in clinical trials. And what that means is that people on placebo get worse in accordance with the disease. So there's a progressive disease and people get worse very slowly, but they get worse. And with the drugs, we bend the course of the disease and make it flatter on average, so that people who are on drug get worse on average slower, okay? There's still disease progression, but it's slower. And it looks like that bending, this part, is about 30%, give or take a couple percent. And the way that that works is that over a year and a half trial, instead of hitting a certain point, maybe having difficulty with checks or picking up the grandkids or any other dysfunction, you hit that point on placebo. The people who were on placebo hit that point in about a year, and it took people on the drug a year and a half, about a year and a half, to get to the same point. So in terms of time saved, it looks like about half a year based on a year and a half trial. And then both the drugs really reduce the amyloid. They do what they say they do. They do what we want them to do, which is reduce the burden of that amyloid. Side effects. No drug comes with a free lunch, right? I mean, there's no such thing as a free lunch. Every drug has side effects. For this drug class, infusion-related reactions are pretty frequent, and they consist of flu-like reaction, mild fever, joint pain, muscle pain, kind of feeling lousy, malaise. They're typically mild to moderate, more likely to occur with the first few infusions, and then they fade over time. We can treat those with NSAIDs, it's over-the-counter medications, antihistamines like Claritin. And I have a couple of people who had more moderate infusion-related reactions, and we give them a steroid right before an infusion. It seems to tamper it down, and then we kind of reduce the steroid, eliminate it, and people are okay. The other side effect is a bit more concerning. It's called ARIA, amyloid-related imaging abnormality. And what that means is that we're getting rid of the protein out of the brain. And the protein sticks in these tiny little blood vessels. And by getting rid of the protein out of the blood vessels, leaks happen. And what's supposed to be in the blood vessel, which is fluid, leaks out into the brain edema. And more rarely, a bigger hole will form in the blood vessel and cells will leak out into the brain. And they will tattoo the brain with ARIA-H, amyloid-related imaging abnormality hemorrhage. And we see that on MRI. So when we see it, and differing drugs have different rates of this, we hold the dose, and it's usually asymptomatic. Again, it's an imaging abnormality only. And to keep it an imaging abnormality only, we get these MRIs. And the MRIs show us the brain edema, we hold the drug, and keep it asymptomatic. However, rarely symptoms can happen. And the symptoms can be mild, a headache, visual change, confusion, and it kind of fades over time, but these can become more severe. And folks who are more likely to get that have a copy of a gene called ApoE4, and that puts them at risk of the disease. So they can't get rid of that protein out of their brain, but they also can't get rid of it out of their blood vessels. And they have more protein in their blood vessels. And some people have one copy of ApoE4, and other people have two copies of ApoE4. Profound risk for Alzheimer's disease, but also a risk for this treatment. And the people who are 4/4 are at the highest risk of having this side effect, ARIA, or brain swelling. So we mandate everyone needs to undergo genetic testing before starting treatment so we can personalize their risk. So the risk is individual based on the genes, but it's also an individual decision based on risk tolerance. I mean, how much risk is one willing to take to get that benefit that we talked about before? Okay, symptoms of ARIA, I kind of went over before, but mild to moderate would be headache, visual change, a bit of confusion, maybe dizziness, nausea, and walking problems. Again, kind of fades over days to weeks. But more serious ARIA can happen, and that can consist of seizures, a prolonged seizure called status epilepticus, being confused, lethargic, stuporous, and even focal neurologic deficits that mimic stroke. So for this, there's a general prohibition on getting IV thrombolytics for stroke, especially in the first 6 months. We tell all of our patients, if you have any symptoms that are concerning, not just a headache, but a headache with a visual change, a headache with maybe a language problem with dizziness, then call me. Call the neurologist right away. And then if worse, or after hours, you can't get hold of somebody, which, again, kind of speaking for every site out there, probably write to the emergency room and then tell them, really, I'm on this anti-amyloid therapy. I'm on donanemab, I'm on lecanemab. Make sure that's part of the medical record so that a stroke could not be treated, because there could be a stroke mimic. And then report the symptoms to the infusion center so that we absolutely get an MRI before the next dose. So that's happened many, many times. People have had a headache or a little bit of spell of confusion, befuddlement, something like that, vague symptoms where we don't dose and we get an MRI just to make absolutely certain that we're not dosing through that brain swelling, which we do not want to do. Monitoring. The burden of therapy is high for this drug, for these two drugs. There's an MRI before anti-amyloid to find good fits, meaning that there's going to be a bad fit. There are MRI exclusion criteria that make this impossible, cannot fit into the therapy. But for those, it's good and everything's discussed and the MRI looks good, then first dose. And the drugs differ in terms of their MRI surveillance. Lecanemab has less MRIs before 5th, 7th dose, and then every 6 months. Donanemab, the other one, has a little bit slightly higher risk of ARIA, and so more MRIs before the 2nd, 3rd, 4th, and then every 6 months after that. Okay, so how would a patient or caregiver know that this is a good fit? Well, they wouldn't necessarily know. What the physician is looking for is really strict criteria. We want to make certain that the patient is otherwise healthy, that they have appropriate future lifespan. There are a lot of MRI characteristics. So those little bits of blood that leak out into the blood, into the brain, that can happen naturally. And if they happen naturally and you have 5 or more little bits of blood, we call them microhemorrhages, then this drug is off the table. These drugs are off the table. They're not appropriate. There are some other eligibility requirements that we look for in sort of judgment of the clinician. That is, the patient, caregiver must be able to travel to get the MRIs and get the infusions. It's really optimal that the people have informed consent. That means they understand the information, they understand their personal risk, especially regarding the ApoE4, because there's a big swing from non-carrier, 1 copy of ApoE4 to 2 copies of ApoE4. So optimally, that's disclosed, it's understood, the risk is personalized, and then you can move forward. We have to understand these medications, this class of medications, is not a cure. It does not stop, it does not reverse disease progression. People do not necessarily get better with them. That we have to just go by the average from the trial. And the average showed it slowed down disease progression. So progression will happen, and that should be expected. So the expectation of these therapies is a little bit tricky but it's going to progress slower than it would have otherwise. We look for caregivers to help us with transportation, symptom monitoring, these potential side effects that can crop up. Thank you so much for joining me. I hope this has been educational for you and we got something out of it. I appreciate you. Thank you.